Good afternoon, good evening. Thank you so much for joining us for the weekly special briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing covers health emergencies across the continent. And today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based in DRC. Dr. Ngashi is also a special advisor to the Director General. Other technical experts joining us on the call is Professor Yap Boom, the Deputy Incident Management Support Manager from IMST based in DRC. I will now hand it over to Dr. Ngashi to start the session. Over to you.
Thank you very much, Director. A warm welcome to all the participants. I think we are grateful to have you again this week for another press briefing. I think we take place in a very positive context, if I can say so. I think we've started now seeing also some light at the end of the tunnel. We are going to take you through the situation on Mpox and other outbreaks that are happening on the continent. I'm just making this presentation on behalf of the Director General, who is just preparing to travel right now. Just to start to say that the Director General has continued his strategic engagement with our leadership on the continent to address the challenges we are facing on Africa's health financing following the recent cuts in global health that have really pushed Africa CDC to rethink again carefully in consultation with all the member states and release what is now considered called the Green Book. It is the African strategy to address the health financing gap on the continent. I think for that he met the president of Equatorial Guinea, President His Excellency Obiang Nguema, there to discuss the situation and also learn more from the experience of Guinea, Equatorial Guinea. As you know, this is one of the few countries in Africa that really contributes more than 90% of the health resources from domestic resources. I think that is a very important activity that the DG will continue to engage with our leadership to make sure that Africans can own the solution to the funding gap in global health. Next. Now, coming to emergencies on the continent and public health event, we look at the first 17 weeks of 2024 and compare them with the first the first 17 weeks of 2025. We had in total 117 events of moderate and high risk in 2024. And this year, we're already at 120, just showing that the situation is not reducing, but if anything, we still maintain the cap toward an increase. Of that, we had this year 34 high-risk events and 86 moderate events that have been reported. But when you look at the different outbreaks or different public health events that have been reported, I think the top 5 include Mpox that we are briefing you today and cholera that come in second position, affecting 19 and 17 member states. We also have dengue affecting 8 member states, flooding in 5 member states, and Lassa fever in 4. And you'll notice from also the map that it is mainly that middle part, the middle belt of the continent, that include West Africa, Central Africa, and East Africa, the 3 regions that are the most affected. Now, coming to the situation of Mpox in particular, what we can say that now, since the beginning in 2024, we have accounted about 129 711 cases, of which 29,609 confirmed, with a case fatality of 1.3% among the suspected cases and 0.6% among the confirmed cases. And also that when you look at the graph, I think there is something that is very interesting, is that Sierra Leone has also joined the most affected countries that have been dominated by three countries, that's DRC, Burundi, Uganda, but now we have the fourth country, which is Sierra Leone. Now, but when you look at the specific data on the week 17, on the case notified, the confirmed cases, and also the deaths among suspected cases and the deaths among confirmed cases, we see that they have been an upward trend when we compare with week 16. But at the same time, we also looked at the total number of cases, both suspected and confirmed, we had in 2024, with the cases we have just for the first 17 weeks of 2025, which represent 1/3 of the total number of weeks expected during a year. Already, we have reached 2/3 of the number of cases that were reported in 2024, both the suspected cases and also the confirmed cases, just saying that we have definitely a much higher burden of cases, both suspected and confirmed in 2025 compared with 2024. In addition, in week 17, Sierra Leone, DRC, and Uganda, those three countries contributed 93% of all confirmed cases during that week. But very important to also say that Sierra Leone alone accounted for half of all the confirmed cases. And there you can see that it's Sierra Leone that is now leading the upward trend that we see on the continent, especially when we look at the past 6 weeks. Now, diving into the Sierra Leone situation, now we have a total of 1,483 suspected cases that have been reported, of which 861 confirmed with 7 deaths. That reflect a case fatality rate of 0.8%. But during week 17, we've seen both on the cases notified, the cases confirmed, and the confirmed deaths that Sierra Leone has maintained an upward trend. Of great concern, as you can see that in just 1 week, the number of notified cases have increased 71%, and the number of confirmed cases have increased 63%. That to say, it is really an epidemic that is on the upward trend. But looking at who is infected among the confirmed cases, males still make 68%. And when we look at the age, I think the age of 30 to 35, which make 25% of all the cases. And of course, we are dealing with clade 2B in Sierra Leone, and women are also affected and make 2% of the cases that have been reported. But when we go on the testing side, I think Sierra Leone still has a very good testing coverage and testing rate of almost 100% of all the cases have been tested. And also important to say that there are now 9 districts that have been affected, of which 6 are still active, with the hotspot still localized in the western area, both in urban and rural areas of the western area of Sierra Leone. Now, the active case searches continue with the initiative that the country has launched, which is called Operation Find Them All. We have seen confirmed cases that have really rapidly increased from less than 10 cases in week 3 to over 200 cases in week 17. As you can imagine, that also takes into consideration the contribution of the Operation Find Them All. But the weakness still remains on the contact identification. Only 764 contacts for 861 cases that have been confirmed, giving a ratio of less than 1 contact per confirmed case, when we actually expected a figure around 20 contacts. Also, what we can also say that to explain the high number, we looked at the reproductive number of Sierra Leone, which stands at 2.3. It is the highest, I think, of all the countries now, with 800 active cases, but important to say that most of these cases are being taken care of at home, I think through home-based care. And also important to mention also that in the hotspot of Western area, that's also where you find high numbers of people living of HIV, meaning that we see that high severity, then that is also following the comorbidities with HIV infection. Now, among the confirmed cases that were also tested for HIV, about 7% of them were HIV confirmed, just to say that people living with HIV constitute an important high-risk group in Sierra Leone. Vaccination has been launched since May 7th. Over 23,000 have been vaccinated, of which 59% were the healthcare workers. I think that's where the country wanted to start. But the target group for vaccination also include the contact and other high risk groups in those hotspots in Western area that I just mentioned before. There are many challenges, as you can see, that explain the situation as it is exploding there, is that the health system is really overstretched and overcrowded. They have a bed capacity in Mpox treatment centers of only 60 beds, but we are talking about 800 active cases, the reason why many of these cases are being taken care of through home-based care. But at the same time, there's also a huge challenge related to the home-based care, is that there's very low isolation compliance. It is very difficult to maintain people in their homes. They tend also, despite being isolated, to continue participating in social activities and then exposing more members of the community to the virus. I think the weakness in contact tracing is only less than 1 in every 6 confirmed cases that have had the benefit of contact identification, and the genomic sequencing also, which should be around 5%, is still very low, below 1%. I think those are some of the key systems weaknesses that have been identified in Sierra Leone. But in terms of the response, I think the Continental Incident Management Support team had a mission to Sierra Leone to go and assess the situation on the ground and see what assistance and resources are needed to really boost the response. One of the interventions so far is the strengthening of the response capacity in the country. There have been training for infection prevention and control, and also case management. Work is ongoing to also boost the laboratory capacity with the provision of the lab supplies, including the sequencing also reagent. As you see, they are still below 1%. And there's also technical support being provided in support of the vaccination that was launched on May 7th, as I said, risk communication and community engagement and other technical areas of the response. And as we move forward, I think following the recommendation of the IMST team, there will be an acceleration or urgent attention that will be given to accelerate the scale up of vaccination, to intensify the surveillance, especially active surveillance through community health workers, also to continue to increase the laboratory capacity, and also support the home-based care, while at the same time also expanding the bed capacity in the treatment centers to keep as many confirmed cases as possible in the health facilities. Now, the situation in the DRC now reflect that DRC account for over 99,000 cases since the beginning of 2024, over 18,000 that were confirmed, and 105 deaths among confirmed cases, and 1,751 among suspected cases, giving the case fatality rate of 0.6 among confirmed cases and 1.8 among suspected cases. I think we'd say that the trend on the mortality is going toward a reduction. But when you look at the situation in week 17 on the cases, we recorded an increase, a slight increase of 0.5%, just from 2,693 the previous week to 2,707 in week 17. But we observed a reduction, very significant reduction, about 35% on the number of confirmed cases. And children below 15 years make 36% of all the cases that have been registered. On the testing side, I think we've seen improvement in the province of Kinshasa, where the testing coverage has now reached almost 60%. But there's work also that is ongoing to harmonize data from the other provinces to establish now the national testing coverage rate. And on the testing rate, I think they stand at 97%, meaning that all the samples that are brought to the laboratory are being tested, and the test positivity rate is now at 38.9%, which is a good reflection that the active surveillance is now kicking in, and we are seeing patients that are being identified much earlier. Now, we had reported in previous presentations the insecurity situation in the Kivus, in the Eastern DRC. We can now report that the situation is stabilizing, and we have started also redeploying the response there. I think vaccination activities have resumed in South Kivu, and the deployment of also key staff is also ongoing now to support the intensification of the response that the government has now launched. In Uganda, some good news coming out of there. A total of 6,371 suspected cases, 5,723 that have been confirmed, 40 deaths, with an overall case fatality of 0.7%. But when you look at the situation over the last 4 weeks, we see that the trend is now on the decline. And the same trend was also confirmed during week 7 in comparison with week 17 in comparison of week 16, where the numbers of confirmed cases dropped from 177 to 160 with 0 deaths, I think that have been reported. And also when you look at those that are affected, males make 56%. Uganda is still dealing with a clade 1B. And on the testing side, the testing coverage is 100%, which is doing very well, meaning that all the suspected cases have the opportunity to be sampled and tested. And the test positivity rate is at 53%, which is still of concern, meaning that there are still areas that need to intensify the active case search. Now, in Uganda, right now, 21% of all confirmed cases in week 17 came from Uganda. But the good news is that when we compare with the peak week, that was week 11, there has been 60% decrease in the number of cases. I think that is really good, the trend that we are seeing in Uganda over the last 6 weeks. But we also wanted to say again that in Uganda, mortality has been reported, but 55% of the deaths were among people living with HIV. So that HIV was one of the risk factor for the high mortality that was reported in Uganda. And also we look at the situation among the 10 districts that are the most affected. We observe the same trend that in at least 8 of these 10 districts, the number of cases are going down consistently over the last 6 weeks. There are only 2 districts, Masaka City and Ohima City, where we still have the upward trend, meaning that as we have entered the acceleration and intensification phase, I think those are the districts that are being prioritized for this second phase to ensure that the entire country can accelerate the control of Mpox. In Burundi, it is the same situation. Over 8,000 suspected cases that have been reported, 3,843 confirmed. Only one death. I think Burundi is one of the countries that has done very well with a case fatality of 0.03%. But when you look at the situation in week 17, there was a slight decline on the number of notified cases, but also a slight increase on the number of confirmed cases, but mortality has been maintained at 0. And the profile of those that are confirmed males make 52% of the cases. Children represent about 38% of all cases. And Burundi is still dealing with clade 1B. Dare to say that this is also one country that has really achieved very good testing coverage, with 100% of suspected cases that are tested, and the test positivity rate now standing at 46%. Now, currently, there are only 81 active cases that are under care. Again, as it is the case with Uganda, when you look at the decline, from the peak week in Burundi, which was week 43, we can say that there has been an 84% reduction in the number of cases. I think, but very importantly, that Burundi is one of the countries that is on the acceleration phase, and active surveillance, is really expanding. And we have started now seeing that it is really working and interrupting the chain of transmission. On the vaccination side across the continent, we have 10 countries that have received vaccines already. And of these 10 countries, 7 countries are currently vaccinating, including Liberia that launched its vaccination last month in April, on the 16th of April. Now we are also hoping that if Angola, which is scheduled to receive its vaccines tomorrow, receives it, then the number of countries that have received vaccines will increase to reach 11 countries. Now, there have been 622,000 people that have been vaccinated, and at least 14 countries where emergency use authorization had been approved, at least for the MVA-BN vaccine. And also, Uganda and DRC have been approved for the third round of allocation of about 743,200 doses of vaccines. That's an allocation that took place last month on the 16th of April, and we are in the process of deploying those vaccines. And also some of the highlights, I think, as we said, it's more than 685,000 doses that have been administered. DRC account for the vast majority of those, that they make 84% of the people vaccinated. As we say, that we are happy to see that vaccination resumed in South Kivu 2 days ago, following the long period of interruption because of the insecurity. And also that Sierra Leone has also started the rollout of vaccination, and they have already reached 27% of the target population. We also want to say that across, at least for the DRC, that has included already children below 18 years, they make 24% of the total people vaccinated. And we are hoping that the other countries will very soon also grant authorization to use those vaccines. Now, also switching from Mpox to cholera, I think we look at the situation on the continent, that there are 15 countries that reported cholera cases in 2025. And the total number of cases reported since the beginning of the year comes to 71,829, of which 1,653 giving us a case fatality rate of 2.3%, which is still considered very high. And I have to say that there are 4 countries, that's Angola, Sudan, DRC, and South Sudan, that make 90% of all the cases of cholera that have been reported this year. But for the single week of AP week 17, there were 3,718 cases that were reported, which is a 9% increase from the previous week. And on the mortality side, 103 deaths that were reported. That's a 77% increase from the previous week. That to say that the cholera situation is still of great concern. Now, if you look at the table that is there on the down left side, you see that South Sudan has reported just this year 22,301 cases. Angola has reported 15,000, DRC 18,000, and Sudan 9,000. And also on the mortality, we see across the board in all countries mortality that exceed 2%. That's also of great concern. Even when you look at the proportion of children below 15 years that are affected, they make really a significant proportion of the cases. 47% in South Sudan, 35% in Angola, 45% in the DRC. And also when you look at the incidence of cases per 1 million population, we have South Sudan that has got 183 cases for every million population, and the same 39 cases in Angola, 16 cases in DRC, and 17 in Sudan. That to say that really there's need really for an urgent action, a continental approach that is rapidly needed, building on the Mpox experience to also support the continental response to cholera in Africa. Now, they're trying to deep dive in Angola. We see that the cases in Angola are still on the upward trend. 17,967 cases already reported, 576 deaths, with a case fatality among the highest, estimated at 3.2%. I think 17 provinces that are affected. But when we look at just week 18, the number of new cases reported comes to 1,865, but that shows a decrease from the previous week of 7%. And the case fatality, I think there were 29 deaths that were also reported the same week. I have to say that 91% of all cases and 91% of deaths come only from 5 provinces, which are the provinces of Bengo, Benguela, Kwanza Norte, Ikolo Bengo, and Luanda. I think that's where most of the intensification actually is taking place. And looking at who is affected, males make 54% of cases and 63% of deaths. And children below 15 years make 35% of all cases and 33% of deaths. But it's also important to say that there are still 1/3 of cases that die outside hospital. I think which really need to intensify the case finding and also care-seeking behaviors to get everybody into the hospitals to take advantage of the good care there. Now, in summary, we'll say that we have some good trend on the Mpox cases. As I say, some light at the end of the tunnel. We see the situation in Rwanda, Uganda, now joining Burundi, also on the decline. We see the situation in DRC that is now plateauing. I think those were the initial high burden countries. We are still concerned about the exponential growth in Sierra Leone. I think over the last couple of weeks, I think that's where most of the attention is really taking place, as I reported about the IMST mission there. And also that the deployment of vaccines is showing some impact. I think the data from Uganda shows that those areas that have been vaccinated, we see a clear reduction in the number of reported cases. But as I said, the focus should be now also on the cholera outbreaks that has been reported in many countries, for which a regional and well-coordinated response in the like of Mpox is urgently needed to help us curb the spread of cholera on the continent. I think that's the essence of what we wanted to share today, Director. Back to you for the questions and comments.
Thank you so much, Dr. Ngashi. Let's cross over to the chat group and take the first two questions. We have James Kunda from Anadolu News Agency. The question is, with the withdrawal of SADC mission troops from Eastern DR Congo, has Africa's CDC equally attained the establishment of a humanitarian corridor to reach out to North and South Kivu? That's the first question. We take the second one from Flavia Nakasa of the Uganda Radio Network. The question is, local authorities in Uganda do not give regular updates on the status of Mpox in the country, but there are anecdotal information that the cases are on the increase. What could be driving this? Over to you.
Yeah, thank you very much for those very interesting questions. I think on the first one, on the humanitarian corridor, there are a lot, despite the withdrawal of the SADC troops, as you have seen, there are a lot of peace processes that are ongoing, led by the US, led by Qatar, led by the African Union. I think that have led to the slowdown of the fighting on the ground and the slow return of the situation to normal. Now, as we say that the situation is much calmer, all the humanitarian organizations have now decided to bring back the key staff, including all of us, Africa CDC. We have also deployed our expert already in the Eastern DRC, and most of the activities have resumed. That's to say that I think there's some positive progress that is going on the Eastern DRC. Now, the situation of Uganda, as you say, that the authorities are not sharing the data locally, but as you can also appreciate that Uganda has been sharing the IMST data on a weekly basis. I think this is the data that we are also sharing with you. Just to say that we've seen that willingness really to share that information, but the teams on the ground will also work with the ministry to see if there could be another process of sharing that data from the Ministry of Health itself. Back to you, Director.
Thank you, Dr. Ngashi. We have the next question here from the chat group. We have Yidrik Lema. The question is, with Africa facing multiple health crises, including Mpox, Ebola, and cholera outbreaks, what immediate strategies is Africa CDC deploying to support affected countries? That's the first question. The second question is on the decrease of ODA. The question is, with the extent of changes in policies or funding mechanisms impacting the continent, humanitarian and emergency, affecting the continent, what is Africa CDC's response to this decrease in ODA? The other question here is Africa CDC receiving any technical or logistical support from international partners like China in response to the current outbreaks across the continent? Over to you, Dr. Ngashi.
Yeah, thank you very much, Director, and thanks for those very good questions. I think on the first one, it is true, as you saw even the map that we showed on the number of public health events that have been reported just over the first 17 weeks, that Africa is facing multiple outbreaks. That is the reason why we have come up with this continental initiative on emergency preparedness and response. That has got three main components. One is the immediate outbreak response, as we are doing now with the IMST and the Mpox. And that is one. And the second is the strengthening of health systems to prepare our member state and our continent to be able to resist and also to reduce some of know the main risk factors. And the third is to push the local manufacturing to be able to really produce essentially the key medical countermeasures on the continent and have a stockpile that allows us to intervene successfully. Now, if you see also when we have reported to you the way that we are addressing current outbreaks, we have even adapted the strategy to have an integrated strategy. Right now, you've seen we started with a focus on Mpox alone. We've shifted toward an integrated strategy that includes also the care of measles and chickenpox. That's where we are moving, so that the opportunity of the response to one outbreak also opens up to addressing other concurrent outbreaks, as well. And secondly, we have another component of the response that looks at the resilience of the system as a legacy, where we are now strengthening the key pillars like surveillance, laboratory, to make sure that we have enough capacity on the continent to also address, other ongoing outbreaks. And a very good example is the evolution of the current IMST, which is being expanded now very soon to also take care of the ongoing cholera outbreak. I think those are the three main strategies that have been really put in place to make sure that we manage very well the ongoing crisis right now, not only one, but take as many as possible. But at the same time, we build a very strong system to have a good, strong surveillance, strong laboratory, on the continent to be able to prevent future outbreaks. At the same time, we also prepare the continent to have the necessary commodities and that are important to respond to all those outbreaks that are most prominent on the continent. And then there was a question on the declining ODA, if Africa CDC has got a response. The answer is yes. We have released the African strategy on health financing. And we have spent the last 1 month really disseminating that strategy, which we call the Green Book. I think if you go on the Africa CDC website, you'll find that document that is there. Really, we are disseminating it everywhere. We started first with the political leadership and technical leadership on the continent, including our head of state and our ministers of health. It has also been disseminated with the key partners around the world. In that response, we have 3+1 pillars. Pillar number one is that we are pushing the increase of domestic resources in the continuation and also drawing the lesson from the Abuja target of 15%. That is one, and you have seen President Kagame. We worked with President Kagame to convene a meeting of the head of state to now re-strategize. That was just last February, to re-strategize in the current context how government can put in a bit more money than what has been happening. The second strategy into that is innovative financing. I think we are also pushing, working with the private sector and many partners to come up in Africa with some of the strategies that can allow us to raise funding beyond the national budget. Things like airline taxes, the sin taxes on tobacco and alcohol. I think there are different strategies that are being discussed right now that will allow Africa to generate more resources. And finally is the blended finance, where we are also trying to see how we can attract the private sector elsewhere around the globe to come to Africa and invest in our local manufacturing, invest in our digitalization agenda, to make sure that that's a business that allows us to do business, but a business that is a win-win, to produce those medical countermeasures locally and advance also that area. I think those are the three main strategies of Africa CDC to try to relieve at least the shock that we've had on the recent cut. But underlying all that, as I said, 3+1 is what we have also included the focus on efficiency. Efficiency means I think we promote all the strategies that help reduce the corruption, or also digitalize some of the things and apply some of the interventions that are also cost saving. For example, instead of multiple face-to-face meetings, some of the meetings could be online to try and save some money. I think there's an entire pillar also that is addressing that. I really encourage you to go to the Africa CDC website, get the green book. It explains in details the strategies of Africa CDC to deal with the declining ODA. And the last one was whether we have received support from partners on the Mpox. I think we have to say that there were multiple partners that have contributed to the Mpox response. It is one of the success stories that we are going to tell. The budget we had prepared for the first plan was 599 million. We received the pledges around 1.1 million. And when we're looking at the report of the 6 months, I think there was already 700 million, I think, that were deployed. Most of that money came from the partners. I think member states did contribute, like DRC, Rwanda, Burundi, Gabon. There were a number of member states that did contribute. But the contribution of member states was less than 10%, far less than 10% of the budget. Most of it came from different partners in Europe, in America, in Asia, that all contributed to the Mpox response on the continent. Over to you, Director.
Let's cross over to the floor. We have Janice from Bloomberg. You have the floor.
Hi, good afternoon. Thank you. I was just thinking with this foreign aid reboot and the Africa CDC, as you've just been speaking about, the green paper, has really had a good, long, hard think about funding and what they're going to do with money. I was just wondering what your views are in terms of the overlap between Africa CDC and the WHO in Africa. Do you think that the WHO should be playing more of a supporting technical role in emergencies and leave the operational issues to Africa CDC? What kind of talks have you had at this stage about where you each going to focus and how things are going to be divvied up?
Thank you, Janice. Let's take the next question before Dr. Ngashi comes in. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Thank you. So I wanted to know, after the visit of the Africa CDC team to Sierra Leone here, among all the observations, the issues, the factors that you saw that may have led to the flare-up, what is the one thing that you think was most responsible, and your recommendations, which one can you single out that you would want to see the authorities particularly focus on among all the other recommendations? Thank you.
Thank you. Over to you, Dr. Ngashi.
Yeah, thank you very much. I think let me thank Janice and Kemo for those questions. If I start with Janice, I think the answer is yes. There is complementarity between Africa CDC and WHO. And the work around health financing has got a lot into it. For example, right now, some of the things that are of the comparative advantage of Africa CDC. When for all these countries, if you had made your plan because you were getting, a salary of 1,000, and suddenly your income is cut to 200, I think the very first thing that you do is to reprioritize. I think work that these countries have to do is that if the resources that are being invested in health have gone down, the country need to look at their national health strategic plan and then reprioritize the areas that are critical, that need to be sustained, and some of them that need to be given less attention. Even the strategies for the implementation of those plans that can also be cost saving. As I was saying, face-to-face meetings and things like that. What's the place of, for example, telemedicine? If you can't get specialists into certain areas, it is too expensive. Those are some of the areas that, to give that as an example, where you have really the comparative advantage of WHO, that these countries will need to be supported to revisit on to reprioritize their strategies on health. These countries will need to be also supported to estimate the new needs now and develop national financing strategy, health financing strategies, I think those are the areas that WHO can really help very much in terms of funding what need to be funded that can help these countries maintain the gains that they have been and continue on the path toward universal health coverage on one side and greater health security on the other side. But there are also areas that Africa CDC is unique. For example, mobilizing the political leadership to commit domestic resources. I think those are the areas that Africa CDC is very well positioned. Mobilizing the political leadership to agree on the continental innovative financing system. For example, if you can agree that the entire continent has to be putting some money into the airline tax levy, to be able to fund public health on the continent. I think those are the areas that we have the comparative advantage of Africa CDC. Just to say that there is a very important role that WHO has to play, especially on the technical, strategic and technical side for as we move toward this agenda of addressing health financing on the continent. Now, for Kemo's question about the IMST mission, what is the one thing that was observed? I think from the Minister of Health, the most important thing is that funding is the main issue. That is from the government side. Funding is the main issue. From the IMST, we also understood that funding was a main issue because the system is weak. For example, the system is weak, that it needs to be strengthened. And when we look at in this current response, surveillance is still mostly passive surveillance. That's why you saw the positivity rate, in Sierra Leone, that is far above 50%. It means that the people come when they're already very advanced. They come on their own to seek care instead of active surveillance that can pick them early and shorten the exposure of the population. Secondly, even the capacity to provide care for those that have already been tested. You saw, for example, when I presented, only 60 beds that are there to take care of 800 people. Now, as a result, that most of these people are at home, and then even compliance with IPC is a problem. You see somebody who's on home-based care, when there's a family funeral, that person leaves the home-based care, goes to attend the family funeral, and comes back. I think those are the things that we think are extremely important, that there are those areas that have been identified. Surveillance is a priority area. Laboratory is a priority area. Case management capacity in the country is a priority area. On the vaccination, we are bringing the vaccination. I think that's not a problem. But for those three, we agreed on the clear strategy to implement that. But above all that is what government is also wanting, the resources that can help them then intervene in those areas, technical areas, to be able to get a much stronger system. Back to you, Director.
Thank you, Dr. Ngashi. We have John Songo from Radio Pan-Afrique. John, you have the floor.
Merci beaucoup, je crois que vous m'entendez.
Oui, allez-y, John.
D'accord. Merci d'abord pour la présentation et les interventions des uns et des autres. Ma première question, c'est comme si elle fait suite à celle du précédent qui posait la question par rapport à l'autonomisation du CDC Afrique. Avant que l'on interrompe la séance de la semaine dernière, le directeur du CDC avait dit qu'il irait aux États-Unis pour accentuer la démarche pour obtenir davantage de garanties sur l'autonomisation du CDC. Je voudrais savoir si le docteur Kaseya peut nous dire que les choses évoluent bien et que le continent peut se féliciter d'être sur la bonne voie d'obtenir suffisamment de moyens pour sa garantie sanitaire. La deuxième question concerne la maladie d'anthrax qui s'est déclarée au Nord Kivu il y a, je crois, 3 semaines. Est-ce que le CDC Afrique a des données disponibles par rapport à la maladie en question? Si oui, qu'est-ce qui évolue? Merci beaucoup.
Okay.
Dr. Ngashi, over to you.
Yes, no, if we do have translation, I can continue responding in English. If we don't,
Yes.
I can respond to John in French.
We have translation.
Okay, great.
We have translation.
Wonderful. Now, I think on the first question, the DG led an Africa CDC delegation to the US. I was part of the delegation. And the delegation also went to Europe. It's not only the US. I think in the US, the discussions with the new administration is to just have an understanding of what should be the form of collaboration between Africa and America and the US on public health in the current vision of the new government, the new administration. Very interesting discussions, very open, really, very open discussions that we presented the green paper that we just spoke about when, I don't know if it's Janice who was asking that question. We presented the green paper and also offered that, even in Africa, we consider health not as an expenditure. We consider health as an investment, as an investment that can also attract the private sector, into this, because they will be making a profit. But at the same time, it's also strengthening the system that on the other side for Africa, it will be saving lives, it will be improving the health of the people, and then also increasing the productivity, of the African people. That was very well received because the specific areas, I'll give you an example, I'll just pick one. You have heard that local manufacturing is a priority for Africa CDC and for the African continent. But local manufacturing requires investment. And those that put investment is the private sector. Those that put investment, the drugs, we buy them. We don't distribute locally produced drugs for free. We sell them. And when we sell them, there's a profit that can benefit the investors, but at the same time can also improve access to commodities on the continent. Those are the ideas that we shared with the new administration. They were very well quite received. As you know, they are also defining themselves, how do they translate the current vision into specifics, and we are continuing those discussions, and we remain positive that the discussions are on track. Now, on the anthrax, I think the team in Kinshasa, we have an office in Kinshasa, and the team is there, is working with the Minister of Health to really analyze the situation and also come up with a response plan. I hope that perhaps this is something that we can include in next week presentation if all the data has been gathered and analyzed. I think it's something that we are keeping on the agenda of our next meeting.
Thank you, Dr. Ngashi. We have the next question from Esther Nakazi, a health and science journalist based in Uganda. Esther, you have the floor.
Thank you very much, Margaret, and thank you, Dr. Ngashi. I think you have kind of spoken to what I'm asking, but I would want you to speak to it again for a concrete quote. So I know that Africa CDC and WHO came up with a continental response strategy for Mpox. And one of the things that you have done is to allow countries or to, advise the countries to put Mpox vaccination into routine vaccination programs. I wonder what else you are doing under this continental response strategy for Mpox that was not done before and should be done differently to take care of this. Thank you so much.
Let's take the next one from the chat group before Dr. Ngashi comes in. We have Abdi Mohammed question on Somalia. So the question is, Somalia is currently facing serious concerns about a potential outbreak of Mpox. Given our fragile health infrastructure and limited border control due to ongoing instability, what practical or community-based and regional strategies would you recommend to help prevent an outbreak and ensure early detection and containment of the disease? Over to you, Dr. Ngashi.
Okay, thank you very much for those important questions. I think I can start with Esther's question about what are we doing differently that was not done before. I think that is the question following on this Mpox response. I think, first of all, just the response itself, it is the very first time in Africa that we have a unified continental response to an outbreak. It is the very first time that you find Africa CDC and WHO seated together to be able to push a response. That has also translated even at national level the same, that we see much more coherence in the planning, in the technical assistance, clear division of labor, more efficiencies in our intervention, and really complementarity in what we do, so that there is no fighting between the organization, but instead there's complementarity where we see who is good at what that can lead that way. That is one. Two is also on the resource mobilization. I think we've done very well. As you can see, the fact that we are able to mobilize more than what we planned, it's because we are now bringing all the resources together. And the three is also the traceability, and accountability, for the resources. As you know, we have a tracking system that allows us to track on the finances. Now, if I come down to that vaccination in Uganda in particular, look, Mpox vaccination, as you can see, is something that has never been introduced in the national immunization plan of Uganda or any other country in Africa. This is the very first time that African countries have vaccinated against Mpox. One, it means that we need, first of all, to change, the vaccination schedule to be able to include Mpox. First of all, Mpox on the main antigens that are on the list of essential vaccines to be administered in the country. We are supporting the country to introduce that. We are supporting the countries to introduce that in the vaccination guidelines and schedule of countries. We are also supporting the country to be that capacity in the system to ensure, because even now, if you see Uganda, where the vaccination is taking place in the hotspot in most of these countries. But if it is to stay, then that means that the entire system, countrywide, has to get the capacity and the health workers that have been trained and now integrate Mpox as one of the antigens that, when called upon, they have the capacity to do that. That also goes even with the cold chain equipment that is there to store these vaccines. We also have to make sure that countries do have cold chain equipment that are capable of then storing this once this is done. I think those are the important changes to the system, I think, that need to take place. And in addition, there's to finish, even the health information system on immunization need also to integrate now indicators on Mpox vaccine. That now the government at national level can also be receiving data on the performance of Mpox vaccination, and then be able to make the right decision and take the right actions. In Somalia, Somalia is at risk. I think that is true. Somalia, just as we have done with other countries, most importantly is to do the preparedness. The preparedness includes certain steps. Number one is to ensure that there is a surveillance system that has been now made ready to be able to identify the case when that occurs. What does that mean? Is that there should be a definition of a case of Mpox. What really can we define as this case represent Mpox? That means the skin lesions, the fever, and so on. That is number one. And secondly, people have to be trained to be able to identify that case. That is number two. Number three, there should be a team of investigators that know about, they have been trained about this disease. They can be deployed, go and investigate. That means that's on the surveillance side. We need to get the country ready to be able to identify this disease when it comes. And secondly, also the key strategic point, like the point of entries, because you've seen most of these countries come from other countries. There's no case in Somalia now. The next case of Somalia will come from everywhere, from somewhere. That can come either by road from neighboring countries, or it comes by air. That's the reason why all those point of entries are the point that we need to strengthen that point of entry surveillance to be able to pick the case. That is the first point of preparedness. The second preparedness is the capacity to diagnose. I think Somalia, now we need to look at the national laboratory of Somalia to ensure that we have the equipment, we have the reagent, that if a case is suspected, we can run the diagnosis and be able to identify it. Number three is the case management. If there is a case today, where is that case being to be isolated? I think there should be a facility that is prepared, to be able to then isolate the case and take care of. But above all that, it is then thinking about putting the structures in to make sure that the National Public Health Institute, start thinking about the incident management team, and also develops a preparedness plan, an Mpox preparedness plan, because you are not yet in the response. You are still in the response plan that can then identify those actions that I've listed and budget them and understand who are the contributors that can make the resources available from government, from partners to be able to initiate those actions. Prevention is always better than cure.
Thank you, Dr. Ngashi. We have one last question from Emery Makumeno of BBC. The question is, with the recent floods in DRC capital Kinshasa, which resulted in the death of 43 and about 3,000 people have been relocated to shelters, I wanted to know what kind of response has Africa CDC been able to provide in relation to the April floods, and how is Africa CDC assisting DRC authorities to mitigate a flare of waterborne illnesses for those still in the flooded zones? Over to you, Dr. Ngashi.
Thank you very much for that excellent question. I think CDC, Africa CDC worked with the government of the DRC through the National Public Health Institute. They developed a plan, a response plan, that included a number of interventions. First of all, shelter, food, clean water, and then prevention on the prevention side. Next to that is also the surveillance to be able to monitor in those areas the advent of diseases such as cholera, to be able to pick them on time. We are actively involved with the government. We have the national office of Africa CDC that is in DRC actively involved in the implementation of the plan, but also in the continued assessment of the situation. But as it is now, the situation is getting better because there have not been any more flooding after that. I think we are all monitoring that. But the most important is that when you look at the cause of the flooding, there was the river. It was the river because there were abnormal constructions that were made along the river where the river water should be going. It's also working on the prevention side so that does not occur. I think that will be the next step of the Africa CDC support to the government of the DRC.
Thank you, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I will hand it back to you for your closing remarks.
Yes, thank you very much, all the colleagues, for joining us again for this weekly brief. As you can see, I think it is important to maintain this kind of exchange to also keep you informed of what is happening on the African continent. And the broadening of these press conferences to also address other conditions, I think, is the best way that we can really put out there the necessary information for all those that want to support in one way or the other, to know exactly what they should be contributing to, whether it is in advocacy, that for action by the leadership, action by civil society. That's why I think this kind of exchange is critical when we're dealing with public health emergencies. Number two is that you have seen for all of us that Mpox, it was worth it to really put in place this continental approach to the Mpox response. We are seeing now good development, really positive development in most of the countries right now. We are doing good in Burundi, we're doing good in Uganda. We are also started seeing some positive development in the DRC. I think that is very encouraging for all of you that really contributed with us from the beginning, until now. You can also see that your effort, are paying off, kind of. But at the same time, we know that we are not yet out of the woods. We still have Sierra Leone that is skyrocketing. We still have a DRC that we need to work hard so that it doesn't revert again to the upward trend. I think those are the areas that we look forward to continue to work with you and with the government, all the actors, to make sure that we can get to the finish line. And also that we are opening up, a new ground. It is on cholera. Very soon, we'll be also giving information. We are planning to also adopt the same regional approach that we've applied in the IMST, where we can come together with WHO and co-lead this continental response, and bring all the other key partners, UNICEF, all those that we know can also have the same experience of Mpox, also benefit cholera. And so that it becomes then the business model for emergency management on the continent. I think we thank you again for making the time to listen to us and also have this exchange. And we look forward to meeting you again next week, same day, at the same time. Thank you very much, and have a good day.